Hello and good evening, and a very, very warm welcome to my respected speakers, colleagues, and all people who've logged in, all of them who've logged in for this wonderful session on this beautiful evening on Friday, the 26th of November, 2021. My name is Dr. Amala Nazareth, and I bring you warm greetings from the Emirates Medical Association. And we have gathered here this evening to discuss a very important, very vital topic of venous thromboembolism and its complications in pregnancy. As you all know that as per the Embrace records of 2019, it is venous thromboembolism is the leading direct cause of maternal death. It accounts for 16% of maternal deaths overall in the UK, and 1 in 6 women died of thrombosis in the Embrace report between 2015 to 2018. So it's all the more important reason why we need to gather together to discuss this. And we have two very eminent speakers speaking on this topic. But before I go ahead and introduce them, I would like to highlight a few things about our webinar. This webinar is live and it's live streamed on the MCI Middle East YouTube channel. This webinar will be available on demand on the MCI Middle East YouTube channel. You can type in your questions and answers in the Q&A box and mention the speaker's name if you want in your questions. And you also have live chat support available on WhatsApp during the event. And most important and not the least is that the CME is accredited by MOHAP. So you will receive your CME accreditation after this event, maybe after 14 days of this event, after answering a question and answer quiz that will be sent to you on your registered email address. So I would like to introduce our first speaker for today evening, Dr. Saleem Awani, who is going to be speaking to us on postnatal vascular thromboembolism and its sequelae and how to manage them. Dr. Saleem Awani received her MBBS and MD degrees with distinction from the University of Kashmir, India, and continued with the Royal College of Obstetrics and Gynecologists, and acquired her fellowship in FRCOG in 2006. She's currently working as a senior consultant in obstetrics and gynecology and is also the chair of academic affairs and deputy CMO at the Cornish Hospital in Abu Dhabi, United Arab Emirates. She received several awards, such as a gold medal in her MBBS and outstanding performance awards for lasting contribution in teaching and learning process. Her main interests are teaching in high-risk obstetrics, medical disorders in pregnancy, especially cardiac and respiratory diseases in pregnancy, hematology, thromboembolism, preeclampsia, and management of third stage of labor. She has served as a chair and a lead member for several clinical and administrative committees, including several guidelines, labor ward forum, risk management, perinatal mortality and morbidity, medical executive committees, health and safety and training and education, resuscitation committees, audits, and graduate medical education. She's a member of the Department of Health of Abu Dhabi, involved in clinical case reviews as an expert in reviewer of DOH, Department of Health Authority, and Higher Committee of UAE Medical Liability Board. She's also the chair of the Royal College of Obstetrics and Gynecology, UAE Reference Committee, and a lead examiner for all MRCOG and its OSCE examinations. She's also a lead instructor for the BLS, ACLS, Prompt, also basic and advanced CTG courses, and was one of the champions of the Joint Commission JCI accreditation and contributed towards securing JCI accreditation for Cornish Hospital and implementation of the electronic medical records. She's regular at making presentations and publications in national and international meetings and congresses and medical journals. Our second reputed speaker, who will be speaking and highlighting on the Department of Health guidelines on thromboprophylaxis and pregnancy and postpartum, is Dr. Komal Sandeep Hazari. Dr. Komal Sandeep Hazari has done her MRCP in internal medicine and MRCP specialty certificate in endocrinology and diabetes, and also completed a diploma in diabetes from Cardiff University in 2019. He's working as a specialist obstetrics medicine department of Latifa Women's Hospital for the past 11 years, with experience in managing pregnant patients with various medical problems. She's a member of the PTU committee, which is Pharmacy and Therapeutics Unit, and Clinical Effectiveness Committee at Latifa Women's Hospital. What is most interesting is that she has prepared the guidelines for thromboprophylaxis in pregnancy and puerperium at Latifa Hospital and has been a part of the organizing team and the speaker for regular workshops since the past 4 years on thromboprophylaxis in pregnancy all over the United Arab Emirates. She's been doing yearly audits on thromboprophylaxis in pregnant and postpartum patients at Latifa Hospital, which is also a KPI indicator for the hospital. She's also been involved in various research projects at Latifa Women's Hospital and has participated in research in anemia in pregnancy and outcome of obstetric cholestasis in pregnancy, and is currently working with the COVID-19 team of the Latifa Women's and Children Hospital since March 2020 and has successfully treated more than 1,000 patients with COVID-19, including pregnant patients. So without much ado, I would like to invite our first esteemed speaker on this platform, Dr. Saleem Awani, who is going to speak on postnatal VTE and its sequelae and management. Dr. Saleem Awani.
Good evening. Thank you for inviting me to give this talk on, which is very important, and that's the postnatal venous thromboembolism. Does it have any sequelae? And if so, what is the management? I have no disclosure, so my objective of the talk is to give a brief introduction to the problem and why we need to think of postpartum thromboprophylaxis. We are a lot focused on the antenatal, so let's see what is postpartum thromboprophylaxis. Does it have any implications? And what are the long-term sequelae of venous thromboembolism? What is the effective management, which includes both the diagnosis and the treatment? And I will conclude with some take-home messages. First of all, the question arises why we need to know about thromboprophylaxis. What is the rationale behind this? And if I take you this, first of all, this is an epidemiological aspects of thromboembolism, and this is about global burden of thrombosis and was published in 2016. And what it does say, important elements, was that it's a significant public health concern. It's a leading preventable death, and I want to focus on this preventable death in hospitalized patients, and is a #1 priority for improving the patient safety in hospitals. But what's important that there's a very poor awareness in public about this condition. If one of the surveys showed that only 28% of the population knew what are the symptoms of pulmonary embolism, and if we go on the other side of the spectrum, the DVT only 19%. And we all know the higher the clots, more the risk of embolization. If we take first now, what is the postpartum, why postpartum is labeled as the highest risk? This is a meta-analysis of 14 studies, and which the first one was earlier, that was done between 1966 and 1998. And what was mentioned in that study was that the DVT events happen about 0.3 per day during pregnancy and 0.28 after delivery. So again, signifying one single thing, that postpartum period is the highest risk even in earlier studies. And the recent studies in 2010, what did they mention about the postpartum thrombosis is again the same. There is 5-fold increased risk of thrombosis during pregnancy, but the risk is extremely high, up to 60-fold during postpartum period and up to 3 months after the delivery. Both of these studies are very well-known studies and very big studies. And what about the implications on the pregnancy of its own? It's a leading cause of direct maternal mortality and morbidity, especially in the developed world. And postpartum being a highest risk period, which I mentioned before, that the risk is about 60-fold higher. If we look into the pooled incidence, antepartum is about 118 per 1,000 person years, and the postpartum is 424 per 100,000 person years. And if the lady undergoes a cesarean section, not only it's 60-fold higher, it is double of that. So it's a quite high risk, any lady who undergoes a cesarean section. And what has been seen recently as per the EMBRACE, which is the maternal and babies reducing risk through audit and confidential inquiries in UK, and it didn't show any evidence of decrease in the mortality over the past 20 years, which is a big, huge concern about it. So if we look into the pregnancy and postpartum period, we call this as a prothrombotic defect risk. And what it is, like if we look into the incidence in the first and second trimester, the odds ratio is about 1.6. Go into the first 6 weeks after delivery, it's about 84 folds higher. Again, a high risk, even though the risk reduces, but still exists up to 3 months after delivery. Now, it depends whether it's a DVT or pulmonary embolism or DVT plus pulmonary embolism. And this is what it is. In the postpartum period, whether it's DVT, whether it's PE, alone, pulmonary embolism alone, or it is DVT and pulmonary embolism, the postpartum period is the most risky period in life of pregnant patients. What was the conclusion of this mega study, which is a very big study and has been done over the long period of time, that the conclusion was that there is increased risk of venous thrombosis during pregnancy and the postpartum period. What's especially important is it's very high risk during the first 6 weeks of postpartum period. So if I conclude from this, the rationale for thromboprophylaxis is the postpartum being a VTE risk is higher. There is 50% of the deaths occur in the postpartum period. There is 15-fold higher than the daily risk in the pregnancy. And the risk is about 15 to 35-fold higher than the age-matched non-pregnant controls. But it returns to the baseline, but takes up to 3 months. And lack of what is important and what is the sad part of the story is we don't have a very high level data surrounding the thromboprophylaxis in pregnancy. This is a recent report which is just published in November 2021, about a week ago. What does it say? And this is a confidential inquiry report and comes from the UK and Ireland. What is this? Still the leading direct cause of maternal mortality is thrombosis and thromboembolism, even though the overall mortality is high in the cardiac patients and the neurological patients. But if you look into the direct causes of mortality, thrombosis and thromboembolism remains the leading cause of maternal mortality. And this has, as you see, this has gone up and down, and still for last 20 years, there's no significant decrease in the incidence of thromboembolism, in spite of having 3 guidelines. What was effective was when the first guideline was published, and that was to mainly applicable to the post-cesarean section thromboprophylaxis. There was a dramatic decrease in the incidence of VTE deaths. But as the years passed, last guideline was 7 years ago and has not been showing any changes. Initially, when the guideline was introduced, there was a slight dip in the incidence, but after that, the rate remains the same. And this is same wherever you see, this is in the US study, same thromboembolism being the leading cause of maternal mortality. And the standard of care which these women receive, there is still a huge provision of improvement in the care and improvement in the outcome of these mothers, either from the prevention point of view or the management point of view. So now why there is no persistent decrease in the deaths due to venous thromboembolism? There are certain population-driven changes which may be responsible. Why? Because the women are now getting pregnant, more older ages, they are more obese, they have more risk factors, They have more interventions, especially in the form of assisted reproductive technology, and likely that VTE in pregnancy will become in future more greater a problem. So what we need to do is to pay more attention towards the prevention. As I said, in addition, the poor outcome could be that this is the population-driven changes. Let's look at the other side of the spectrum. It could be that we missed a dose to give the thromboprophylaxis, or there was a delay in giving the dosages, or delayed in review or inadequate review once the patient had symptoms, and which possibly led to the poor outcome in this group of the population. In the present last report, which is published recently about about a week, 10 days ago, the pulmonary embolism, there were total 32 deaths due to pulmonary embolism in UK. Of them, 31 were pulmonary embolisms, and one lady had a CVT, which is cerebral venous thrombosis. Of these, 3 were in first trimester, and 4 were in second trimester, and 25 patients were postnatal. So the huge number of population, even in this last report, is postnatal patients. So a lot of focus needs to be done towards the postnatal management of thromboprophylaxis. Now, if they looked into the standard of care which these mothers received, what was important? Yes, 10% of them received good care. 26, there was not much chance that there would have been any difference to the outcome. But what's important, and the last thing, is that 58% of them had still a substandard care. That is, if alternative management was given, there would have been a difference in the outcome. So let's look into the timing of the deaths. As I said, this is an older study and still very valuable study, which was published in 2008, that first trimester, yes, there can be a mortality due to thromboembolism, but what is most important period is the postpartum. And this is higher in the second week postpartum than in the first week, but it declines over the period of 12 weeks after delivery. So second week is the higher risk than the first week, but significantly reduced after 6 weeks postpartum. And what are the recommendations which came from this report? Very interesting facts and nothing new to us, which we don't know. VTE risk assessment should be consistent, means every patient who comes to the hospital should have a VTE risk assessment. The second important point was, which was not previously mentioned much, that we should be weighing them again at 28 weeks and as well after delivery, because some of the women may gain a lot of 20-25 kilos during pregnancy. So we need to adjust the dosage of the thromboprophylaxis, because our previous thromboprophylaxis was based on the weight at booking, but now being a lot of weight gain during pregnancy, the dose should be adjusted to the latest weight. The second thing is, what about previous patients who have a previous venous thromboembolism history? So we should have a pre-pregnancy counseling in them, and we should have a prospective management plan. The plan has to be continuous, means what is to be done during pregnancy, during labor, after delivery, and how long they need the thromboprophylaxis after delivery. Again, long distance travel of more than 4 hours is a risk factor for VTE. It doesn't matter which route of transport is used, whether it's the air or whether it is by any car or any bus or any transportation mode. Women on anticoagulation, we have to have a very structured management plan, again, including antenatal period, intrapartum period, and a postpartum period. And this is a new, which is that systemic thrombolytics can be recommended for patients who are high-risk PEs, means the patients who are unstable. These patients, we can give them thrombolytics. Now then comes why pregnancy is such a high risk, or postnatal period such a high risk for VTE, because during pregnancy we have normal physiological changes in the body. What are those physiological changes? We are in a stage of hypercoagulability. Why so? Because we have increased level of the coagulation factors, which includes factor 5, factor 7, factor 8, 9, 10, 11, 12, and even von Willebrand's factor. At the same time, when there is increase in these coagulation factor, there is decrease in the amount of natural anticoagulants. That means there is increase in the resistance of the activated protein C. There is decrease in the concentration of protein S and antithrombin, and fibrinolysis is reduced also. So on one side, we have hypercoagulability. On the other side, we have a reduction in the anticoagulants. In addition, we need to remember we have a Werkhoff's triad where there are three things. The third thing is now, what about stasis? So there is venodilation, and there is also renal vasodilation. There is increased intravascular volume, and there is obstruction because of the gravid uterus on the inferior vena cava. So what all these three factors lead to is the venous stasis. Now then what about the thing that is the vascular damage? This is mostly endothelial damage and is related mainly to the time of birth, and that's because whether it's a vaginal delivery or a cesarean delivery, there is some endothelial damage during the process of delivery. What all these lead is the same virtuous triad, that is flow, hypercoagulability, and venodilation. If we look into the risk factors in the VTE, let's look into the pre-existing risk factors where we can't do much. They are existing there. This is somebody who has a previous VTE, or they are already having thrombophilias, known thrombophilia, or they have medical comorbidities like cancers, heart failures, or nephrotic syndrome, or they have a history of unprovoked VTE in the past, age which cannot be changed, or where there's obesity, you can't make it any less at that moment, or they have already had 3 children or parity of more than 3, they are smokers, which can be a modifiable risk factor, and a varicose veins. Now there are obstetric factors, and these obstetric factors include preeclampsia, assisted conception, especially with multiple pregnancy, delivery by cesarean section, if there is a difficult or mid-cavity or rotational operative vaginal delivery, if prolonged labor more than 24 hours, postpartum hemorrhage more than 1 liter, or a blood transfusion during the process of delivery, preterm birth in the current pregnancy, and the stillbirth in current pregnancy. 2 important factors, preterm birth and stillbirth. What about the transient risk factors? Transient risk factors are if a lady undergoes any surgical procedure in pregnancy or prepurium, like appendectomy or tubal sterilization after delivery, or they had hyperemesis, or they had ovarian hyperstimulation syndrome secondary to assisted reproductive technology, or they have any systemic infection or immobility. And presently we had a huge systemic infection, and that was the COVID related, and then dehydration from any reasons. And if a patient is admitted to hospital and is immobilized for more than 3 days, and there's enough evidence that increases the risk of VTE. So let's look into each individual obstetric risk factors, and these are odds ratios for each risk factor. Now, if we take no preeclampsia or no IUGR, the odds is 1. But once there is preeclampsia, but there is no IUGR, the odds goes to 3. And once there is no preeclampsia, but there is IUGR, the risk odds ratio is about 3.5. But if the both of them are existing, that's both preeclampsia as well as there is an IUGR, the odds ratio goes to 5.8, which is almost 6. Now let's look into the second important factor, that's the BMI and the antenatal antepartum immobilization. If the BMI is less than 25, which is odds of 1. Now, if the BMI goes up more than 25, but there is no immobilization, the odds ratio is about 2.4. But if there is both more than 2.5 BMI plus immobilization, the odds goes as high as 40-fold. So obesity and immobilization, got not a good news, increases the risk of VTE. What about the postpartum bleeding? And we know that postpartum hemorrhage is very common, whether it's post-surgery or it's post-vaginal delivery. If it's less than 1,000 mils, the odds is 1. But if it's more than 1,000 mils but has no surgery, the odds is about 4.2. But if there is more than 1,000 mils and plus surgery, the odds ratio goes high to 12. So again, these are the risk factors which we need to keep in mind. So there is the same thing is about the adjusted odds of postpartum bleeding. Transfusion itself is a very high risk. Any patient who had a transfusion during pregnancy or after delivery are at a odds of high risk of having venous thromboembolism. Same applies to the stillbirth and to the lupus. So these are the factors where we have to keep into mind that these patients do have other risk factors. There's a lot of data which is published only on the risk factors. Preeclampsia, as I said, is a bad news. Placenta previa or placental abruption, because of the massive hemorrhage, they are risk factors. Cesarean section, if it's a planned, the odds is about 2.7. But if it's an emergency cesarean section, the odds is almost 4. So again, keeping in mind that surgery is not a best option. What about thrombophilia? There is high risk for the postpartum pulmonary embolism. We know if we compare the patients who are antenatal and develop venous thromboembolism and the patients who are postpartum, pulmonary embolism is more common in the postpartum patients than in the antepartum patients. The magnitude of the risk varies with the type of thrombophilia, with the history of venous thromboembolism in the past, or a family history of VTE, because they will change the risk of having thrombosis. If somebody has a thrombophilia minor, but she has a history of personal history of VTE, she becomes high risk. If she's only minor thrombophilia, but no history of VTE and no family history, she becomes a low risk for thrombosis in the present pregnancy. If we have to think, which one is the worst thrombophilia? You can see the highest risk is when those who are compound heterozygotes. What does they mean? They mean that is they have factor V latent mutation. At the same time, they have prothrombin gene mutation, but both are heterozygous. They are not homozygous. But homozygous for factor latent mutation is also an odds ratio of 30. And even the homozygous for prothrombin gene mutation is high risk. But as I said, compound heterozygotes are very bad news in comparison to the others. Protein C, protein S deficiency, heterozygous are also but they are low risk for thrombosis. If anybody has a previous history of venous thromboembolism, how much is the risk of recurrent venous thromboembolism in pregnancy without any antithrombotic prophylaxis? Very interesting study to carry out, and having no prophylaxis and giving to the patients who have a previous thromboembolism. Now, the question was, should women with previous episode of VTE receive antithrombotic prophylaxis? Which is a very genuine question. But again, it depends upon, does she have any inherited thrombophilia? If there is a high risk if there is a thrombophilia, so no statistically significant increase in the risk of recurrence. She has low risk thrombophilia. But if she has factor V latent or she's heterozygote, then, and she has an unprovoked VTE, the risk of VTE is almost 30% and is 6.8%, which is about 7 times higher than in women without thrombophilia and without provoked VTE. What it means that patients who have a previous VTE, they have thrombophilia and they have a high risk thrombophilia. These women are very high risk for developing venous thromboembolism. The risk of first venous thromboembolism in and around the pregnancy. This is a population-based cohort study, more than 1 million women and age group between 15 to 44 years, and that's the reproductive age. And highest risk which was noted, which is this is in the first trimester, second trimester, third trimester, goes slowly up, but look at the postpartum period, which is extremely high in early postpartum period, and this is the late postpartum period, and this is what is in non-pregnant population. So if you look into what is the highest risk is the postpartum period, and it's highest in the first 6 weeks in comparison to the late postpartum period. Another study showing the same thing. And that's as the risk goes up, the postpartum period is the worst. And of them, the first and the second week of the postpartum period are the highest risk for VTE. Now, this is a risk of postpartum VTE, as I said before, is about 6.5%, and the risk of recurrence is higher, 3.9-fold higher with the prior hormone-associated VTE, because VTEs could be unprovoked VTEs or provoked VTEs. Unprovoked VTEs are where there is no risk at all. The patient didn't have any surgery, didn't have any long travel or anything. Or if they are on contraceptive pills and they develop the VTE, that's a very high risk factor for developing a recurrent VTE during pregnancy, because that's hormone associated, or if it is unprovoked VTE. Now, this is if we don't give them should women with previous episode of VTE receive thrombotic? The answer is yes, because the risk of recurrence is high in the patients who have, especially in the postnatal period, which is about 15.5% in unprovoked and 7.5% in provoked. What's the risk of having IVF? As we know that there is increase in the number of IVFs all over the world. This was a cohort Danish study and was over a period of about 10 years. And this was all IVF cycles, more than around 19,000 IVF cycles. There were 48 cases of VTE. And what did this study show? That VTE incidence was significantly increased in pregnancies after IVF, especially in the first trimester and in the first 6 weeks postpartum. In the first 3 months, the reason being because they have induction of the ovulation with the gonadotrophins, and they are at risk of having the hyperstimulation of the ovaries, and that's one of the biggest risks. And the first 6 weeks is again because of the postpartum period. The risk is much higher if they have associated with twin pregnancy, and this is what happens. If you look into the graph, IVF of its own is a risk factor. This is the preference range here, and if you go to the twins and triplets, and this is here singleton, and this is the risk with the triplets or with the twins. So the twins and triplets are a bad news as far as the VTE is concerned. And same applies whether it's weeks after the birth or miscarriage. The risk remains high in patients who have IVF pregnancies. So IVF pregnancy is a very special pregnancy. They are associated with high risk of having venous thromboembolism throughout pregnancy as well in the postpartum period. So IVF treatment should be included in the antenatal and postnatal risk assessment for VTE. Let's look into the other study, which is a meta-analysis again of the 36 studies showing that thrombophilia is associated with the risk of venous thromboembolism. And of them, homozygous factor V latent mutation, homozygous prothrombin gene mutation, or compound factor V latent and prothrombin gene mutations are high risk for developing VTE, which could be up to 6%. And the variable risk with the antithrombin deficiency, because antithrombin has many types, and it depends, especially if they have associated family history of VTE, they become the high risk for developing venous thromboembolism. Let's look into the mode of delivery. Does mode of delivery make any difference to the pulmonary embolism or VTE? Look at the graph. This is the study which was shown. This is your background risk if we take all the deliveries together. This is here. And if we look into the vaginal deliveries, the risk is lower. And we know this. And if the patients have post-cesarean section, the risk is dramatically high. That's what I was saying in the postnatal period. The risk is high, but it goes much higher, almost double, if the person has if patient had cesarean section. So the risk of cesarean section is particularly very high. And same applies to the same vaginal deliveries and post-cesarean section. All of this is very high risk for developing venous thromboembolism. Now then question comes, what should I do? What's the prevention? What I should do to prevent this thrombosis or thromboembolism happening? The most important step is screening. and that is the VTE assessment. And if we suspect that there is symptoms or signs which could be suggestive of venous thromboembolism, especially DVT or pulmonary embolism, what's important is early diagnosis. If we diagnose it and we can treat to prevent the progression of the disease as well as long-term morbidity, not only morbidity, but as well mortality. So the important first thing is screening, and the second important thing is early diagnosis. Now, this has been done, this should be a part of assessment of the standard practice. This has been recommended by all big authorities in the world or agencies. Like if we take first Agency on Research and Quality, what do they suggest? VTE as the #1 patient safety practice for hospitalized patients. So again, VTE assessment. The second is Joint Commission. All hospitalized patients to have a VTE prophylaxis or documentation why not VTE prophylaxis was given. Again, you will only give VTE prophylaxis if you do the assessment. If you go to the last, another third big authority, that's the National Quality Forum. Again, what do they say? It's a safe practice. Recommendation is routine evaluation of hospitalized patients for risk of VTE. If anything which is important from all three organizations is one point: assessment and management of those who have risk factors by thromboprophylaxis. So the most important safety practice in hospitals is prevention of VTE by doing an appropriate assessment, recognized as a significant international patient safety issue. VTE prevention should be fully integrated in the hospital systems as well as in processes. There should be processes if there is any risk of VTE. The trigger for VTE prevention is the assessment of the risk. And if there is a risk, appropriate preventive treatments can be given in line with the clinical guidelines. And there are lots of international guidelines which you can take into consideration. So when should we assess the risk of VTE? At the same time, we should assess the risk of bleeding because we have to weigh between the two. The first most important time is preconception, if they're coming before planning pregnancy, or if not that, on booking. We should again reassess these patients for risk of VTE when they get admitted, because they might have developed preeclampsia, they might have an IUGR, they might have any reason to get, like they might be vomiting, dehydration, or anything. So we need to reassess all the women, pregnant women, on admission. And if they get admitted and they stay in the hospital and they have a reduced mobility for 3 days or more, or they have any surgery and trauma, it's very important to make that assessment of their risk and also to plan the management, which is thromboprophylaxis. What about post-delivery? Immediately after delivery, they should be assessed about the risk of VTE. Again, keeping in mind the risk factors which can be before existing, but to add to that, the postnatal as a risk factor, and if they have any bleeding or if they have any blood transfusion as an added risk factors. And what is the trigger for VTE prevention? We all need to be ready. The most important thing in the readiness is to have a standardized assessment for risk, tool for risk assessment. That means it should be standardized, it should be same, and it should be used everywhere. Then if we have this, it should be then integrated into the hospital systems. And what it also needs at the same time to prevent it is the education of your whole staff on risk assessment and what should be the treatment if they are high risk. Then is providing the appropriate thromboprophylaxis, which you should be again having a response in the form of having the guidelines. Then there should be a review of if there is any VT event, it should be reported. That means you should have a reporting systems for reporting these VT events and to find out was there any problem on the part of the compliance or it was a system issue, because some of the risk scoring systems are very cumbersome and very difficult to apply at times, and they may not be used consistently by all. Now, what if there is a risk factor identified? So what we need to do, we need to provide them thromboprophylaxis. And what is the best thromboprophylaxis which you can provide during pregnancy? The agent pharmacological agent, which is the best choice or the agent of choice, is use of low molecular weight heparins. What it does do, it reduces the reduction of the VTE, but again, this reduction of venothromboembolism by use of thromboprophylaxis has been extrapolated from the medical and surgical patients. Because if you use thromboprophylaxis in medical patients, it reduces the VTE by 60%. And if in surgical patients, we have been evaluated reduced by 70%. There's only one study which has shown the obstetric thromboprophylaxis and long-term risk of recurrence of venothromboembolism. And this was the study which came from Sweden. And what did it show? That obstetric patients with history of prior VTE, it reduced the risk of thromboembolism or VTE in about 88%. So there are very few studies, but not too many studies to say the obstetric patients and the role of thromboprophylaxis. So what should be the optimal duration of using any of these thromboprophylaxis? Again, not well defined. As I said, it's mostly dependent upon expert opinions, or these are extrapolated from non-pregnant population. And there is so much variations in between guidelines. So let me give you some of the examples of this. This is a transient or intrapartum prophylaxis till discharge. This is should we give, or should they have persistent risk factors, and how long we should be giving. Let's take the Canadian guidelines. Prophylaxis till discharge. If you take American College of General Physicians till discharge, take the ECHO guidelines 2018 till discharge, RCOG guideline, very fixed time, 10 days for intermediate risk factors. Persistent risk factors, most of them are in agreement that they should be given up to 6 weeks. So again, there is a difference in different guidelines. So like in our hospital, we use mainly the RCOG guidelines, and we have been using it over the period of time since 2015, and we update it regularly, but there is not much of a change in the guidelines so far in the hospital. So now you have somebody who is coming with the symptoms of this. She is delivered, she's coming, and she's saying she has a leg pain, she's swelling, and she's not comfortable in walking. So first of all, we know clinical presentation just for a swelling is very unreliable. Now question comes, there is one which is simple parameter is called left, but this is very highly predictive of DVT in pregnancy, but especially in the first trimester. What does left stand for? Left means left is L for symptoms in the left leg. We know that the thrombosis is mainly on the left side. This is because of the difference of the left side being compressed. It's the difference in how the vein is compressed by the artery on the opposite side. E is the calf circumference difference of more than 2 centimeters, and FT stands for the first trimester. So first trimester, if a patient has symptoms on the left leg, you measure the calf circumference, there is a difference of 2 centimeters. Most probably if she has 0 parameter, possibility is low, there is DVT. But if she has one variable, the possibility of DVT goes up to 16. But if she has 2 variables positive, the risk is almost 58%. So quite a simple algorithm, but applies mainly to the first trimester. What about the lab testing? Lot of debate about the D-dimer levels. We all know they are very unreliable during pregnancy. They increase in pregnancy, and the highest D-dimers are found to be in third trimester. But if they come low, so you get reassured, no, this person possibly doesn't have D-dimers. There are now newer studies, but you again need to know which D-dimer, because there are highly sensitive D-dimers. It depends on the lab test which is available in your hospital. And there are some studies, which is the year studies and all those, which are showing some correlation between the D-dimers. But again, most important thing is to think of that this could be possibility of a deep venothromboembolism. And again, we know they return to normal within 6 weeks after delivery. They have not been validated in prospective diagnostic cohort studies. And we know the BNP is another test which can be done. And it remains same in all trimesters and as well postpartum. But what is needed, that we need further evaluation to have a very robust evidence to see which lab test we should be using during pregnancy. But so far, D-dimer has some opportunity to have its possibility, but still more studies are needed. What's the cornerstone for the diagnosis? The gold standard is venography, but compression ultrasound is now the first standard modality of diagnostic aid used for diagnosis of deep vein thrombosis. What you see in the compression ultrasound, you want to see is it positive or negative. And what is that compression ultrasound? You need to see that is this non-compressibility of the lumen in the transverse plane? Is there any echogenic material you are seeing in the lumen of the vein? Or is there loss of normal phasic flow pattern? The sensitivity and specificity is quite good, 95 and 98%. So if the test is positive, you treat it as DVT. If it is negative, but there are symptoms persisting, you assess the risk. Again, if the risk is high, you again repeat the compression ultrasonography. If that's not helpful, you can do MR venogram. If the risk is low, you can discharge this patient safely back home. And we know that about the pulmonary embolism, the symptoms are very non-specific. And we know that VTE being major cause of maternal morbidity and mortality, we don't need to miss the diagnosis, because missing the diagnosis can have devastating effects, and that is the mortality. And we should have a low threshold to test the pregnant women with suspicion of acute PE. Never leave a patient without having a diagnosis by excluding that there is no pulmonary embolism. So what simple thing is, because most of the people who say, no, we should not do the test because they are worried about the imaging and radiation effects. We can go up to 5 rats have not been found having any effects much on the fetus or the mother. So the chest X-ray, imagine the radiation dose is extremely low. If you do perfusion scan, it's only 0.8. And if you do ventilation scan, it's very low. And CTPA has much lower radiations, but maximum recommended dose, as I said, that is 5 rads, which is about less than 50 milligrays. So again, if you do any of these modalities, we need to be reassuring ourselves as well as the radiologist, who sometimes may tell the mothers there is a risk of radiation to the fetus or to her. So keeping in mind about these, the risk is very low. Now I'm going to take you later on, should we do CTPA or we should do ventilation perfusion scans? So, which is debatable, and you can see about why I say about the debate between the two. The presentation, usually when they have a PE, the patient may complain of shortness of breath. What is the problem during pregnancy? Everybody during pregnancy does complain of some sort of shortness of breath. And majority of these shortness of breath may be taken lightly. Or they complain of mild chest pain or a chest pain which is pleuritic in nature, or they may complain of just cough. The only thing I think cough with hemoptysis is sometimes triggered and needs to be evaluated for the reason. Calf pain and swelling, very common during pregnancy, and usually may be missed as normal swelling, edema of the legs, which is mostly seen in most of the pregnant women, or some may come with a very collapsed stage, and that is where you have a massive pulmonary embolism. If you do any clinical examination, they may be tachycardic, they may be hypotensive, they may have tachypnea, and if you check their saturation, that may be low. So if we have any of the suspicion of having a pulmonary embolism, what should we be doing? Yes, the first level comes as doing a quick ECG, X-ray chest, or ABGs. If we have any doubt, it's better to start the anticoagulation with low molecular weight heparin in the treatment doses if they are stable. But if the patient is unstable on this arm, immediately you can do either a portable echo if it's available. If not, or you think it's a massive pulmonary embolism, thrombolysis is the best treatment in these patients because they are clinically unstable. But if they are stable, then you can do the Doppler compression ultrasound. If it's positive, go on with the anticoagulation with the low molecular weight heparin. If it is Dopplers are negative, but you have a high clinical suspicion, then in that case, do the X-ray chest. If the chest X X-ray is normal or chest X-ray is abnormal, then if abnormal, do the CTPA. Again, it is again to exclude, or when should I continue with my anticoagulation? I should stop it. If the CTPA is negative, you can stop anticoagulation. And if the chest X-ray is normal, you can do a VQ scan. If positive, you continue with the low molecular weight heparin. But patients who are unstable, these are the ones who require an urgent treatment, and in that the easiest one to do is an echo, and then depending on the echo findings you can go ahead and do the thrombolysis or IV heparin and thrombectomy. These are all possibilities in these situations. One of the debate about the CTPA is because the exposure to the breast is more with the CTPA than with the VQ scans. So this is a recent systematic review that CTPA and VQ scanning to be appropriate for ruling PA during pregnancy. Both scanning techniques were below the safety threshold of 100 milligrays associated with fetal radiation complications. So fetal radiation point, both are safer. The decision whether to use CTPA or VQ scan should be based on two things: whether it's a user convenience or what is available locally, because that depends upon what in your facility is available. CTPA, we know it has a lowest radiation exposure to the fetus, but the problem is it has higher radiation exposure to the breast. So in that situation, VQ scanning is better for the breast, but the radiation exposure to the fetus is slightly higher, but still within the provision of low risk. So exposure CT during pregnancy or the postpartum was not associated with an increased short-term risk of maternal breast cancer. The long-term risk should be studied. So if I have to conclude from the CTPA VQ scan, it depends what's available and what the people are comfortable with. The exposure, maternal fetal radiation exposure doses are well below the safety threshold, and both imaging tests are equally sensitive and safe and can be carried out in patients where you suspect pulmonary embolism. The long-term sequelae, because we know about it's associated with significant long and short-term morbidity. Not only so, it has a lot of financial consequences and reduction in the quality of life. What we see as maternal mortality is the tip of the iceberg. It's associated with a lot of morbidity, and the two important lifelong morbidities are chronic post-thrombotic syndrome and chronic thromboembolic pulmonary hypertension after pulmonary embolism, and both of them have a long-term consequences. What's important is to recognize about the post-thrombotic syndrome. It has various degrees, and it has I will take you through the symptoms and signs on the next page, and it reduces the quality of life. And there is some degree of post-thrombotic or severe thrombotic syndrome, post-thrombotic syndrome, which can happen up to 10%. What's management is to use the compression stockings, and it can reduce the frequency. At the same time, this recommendation is up to use them for up to 2 years. The symptoms can be pain, cramps, heaviness, paresthesia, itching, and clinical signs are pretibial edema, skin induration, pigmentation, redness, pain in the calf, and or if the symptoms, depending on the scores, you can have 0 to 3 in each symptom and sign. And if the score is 5, that's a mild post-thrombotic syndrome, but if it's 15, it's severe post-thrombotic syndrome. And post-thrombotic syndrome, we know it's a long-term complication after pregnancy-related deep vein thrombosis. The chronic thromboembolic pulmonary hypertension is another major risk to the patients who develop DVT or pulmonary embolism. This negatively influences the quality of life, and it has also an implications which could be physical, social, and psychological domains, and can have the problems on the long term on the infant developments as well. And now there is a big variation in the recommendations about the guidelines, and mostly the guidelines are dependent on expert opinion or have been extrapolated from non-pregnant population, and the variations are huge in between the guidelines. If you have to use the thromboprophylaxis, the best medication to use is low molecular weight heparin. It is predictable, reliable pharmacokinetics, and reduces the bleeding risk and osteoporosis, heparin-induced thrombocytopenia. Aspirin is not recommended for the thromboprophylaxis. If heparin is contraindicated, danaproid is the other medication, but it has a half-life. Oral anticoagulants are not recommended. These are the dosages, and I think every hospital should have this chart in their hospitals to know about the dosages for thromboprophylaxis and as well treatment. Breastfeeding is absolutely safe while on warfarin, unfractionated heparin, or low molecular weight heparins or danaproid. The only thing is low fondaparinux and or other factor Xa inhibitors are not recommended. Low dose aspirin can be continued and is safe to continue breastfeeding if used for vascular recommendations. Thrombolysis in pregnancy is indicated. There are two types. One is systemic and another one is catheter directed. Catheter directed is mainly for occlusive thrombosis. It has a risk of radiation but has a low risk of bleeding, where systemic, it needs a cannula, it has a high risk of bleeding and is less effective in occlusive thrombosis. IV filters can be used but have to be recommended by a multidisciplinary team because they have their own side effects and they have problems which they can undergo angulations and distortion and can be difficult to remove, and even the cases of thrombosis of the filters have been reported. And one of this is only indicated in patients where they get repeated DVT in spite of having thromboprophylaxis. Again, remember, this is what I said so far. And if I have to conclude, I say there's a lot of differences in different guidelines, whether it's RCOG, ECOG, and CHEST, and they have a huge differences in this. What we need is a large studies to, with the post-cesarean thromboprophylaxis, further research is needed for their assessment. And what recommendations? What are the main recommendation or take-home messages? Prevention, diagnosis, and treatment should be priority in all health services. There needs to be tools to, simple tools to help us to do the risk assessment. They should be electronically available so that you can do the assessment as without any much variations. There should be an audit to see whether these assessments are carried out and appropriate thromboprophylaxis is provided. And women diagnosed with pregnancy-associated VTE require a multidisciplinary collaboration, and suspected DVT must undergo diagnostic imaging, and CTPA has a sensitivity of 100% and specificity of 100%, and low dose protocols can be used. Even VQA or CTP, both are safe. What is in future? There are lots of studies which are undergoing, and possibly we will be getting results in this year or two. Bleeding complications have to be kept in mind, and as well the cost, and there are newer agents getting developed which have a lower risk of having bleeding, and possibilities we might be using soon different types of this. What's future? There will be an additional biomarkers possibly available which will help us to predict VTE, have safer medications available, and there will be machines. That's what I call artificial intelligence, which will give us an algorithms, and this will be revolutionize prediction and prevention of this common disorder. And thank you very much, and I want to stop here. Hello. I'm just starting to share my screen, and these are a couple of questions which I would like to just put, and I'm sure all the participants will answer it so easy. And the first one is, from which vein VT is considered proximal? So if I ask the host, Karishma. Can we have voting on this question, please? We can get the answer for this, please. Well, the answer is above the popliteal vein, which only 22% were correct. So remember, anything above the popliteal vein is proximal. So next, let's go to the next question, please. Which one of the following is the greatest VTE risk to the individual? There is an overlap, so just be careful. Immobility, history of VTE after surgery, dehydration, history of VTE during pregnancy, long haul travel, or oral contraceptives. You can vote now. Can we see the vote? Immobility, 28%. The answer is history of VTE during pregnancy is the highest risk, and that needs to be taken care of because this is during present pregnancy as well. So you have to be careful. So 46% have answered it, which is correct. And so the highest numbers are correct. Next question, please. What is the appropriate dose of prophylactic enoxaparin for 128 kg women? 40, 60, 80, 100, 120, 80 milligrams BD. Can we have the voting? Is the easiest question. So let's have the vote. Karishma, can we have the results of the voting? The correct answer is 60 milligrams, and that's 27%, and 80 milligrams was answered by some. I think I had slide in between, and that was about the dosages. So the correct answer is 60 milligrams. I think I'll stop here. Thank you very much. Karishma, we will conclude this. Yeah.
Good evening, everyone. First of all, I would like to thank the Emeritus Society for giving me this opportunity to speak on this topic, which is very close to my heart, thromboprophylaxis in pregnancy and the puerperium. My objectives are introduction to thromboembolism in pregnancy, the burden of the disease, risk assessment for thrombosis and prevention of thrombosis in pregnancy and the postpartum period. As we all know that half of the hospitalized medical patients are at risk for venous thromboembolism. Also, we know that 45% of the DVTs or venous thromboembolisms occur in the 3 months following discharge. So we clearly understand that hospitalization and the immediate period following hospitalization is a risk factor for thrombosis. Now, venous thromboembolism, which may manifest as pulmonary embolism or a deep venous thrombosis, complicates 0.5 to 2.2 per thousand deliveries, depending on the population studied. During pregnancy, we all know that the risk is increased 5 to 10-fold compared to non-pregnant women of comparable age. Also, the postpartum period poses a higher risk, and during this time, the risk increases 15 to 35-fold as compared to age-matched non-pregnant women. One study published in the Saudi Arabia journal showed that the incidence in this local population of Saudi Arabia was 1.25 cases per thousand deliveries. Some publications done in the US, this is during the period of 1987 to 2010, it's very clearly noted that thrombotic pulmonary embolism, the pregnancy-related mortality was around 10% for these years. Following this, another study published in the ECOG from the period from 2011 to 2013 also showed that venous thromboembolism was the leading cause of maternal mortality in the United States, around 9.2% responsibility for all the maternal deaths. This is a very interesting graph on thrombosis and thromboembolism. This shows you the mortality rates from 1985 to 87 to 2006 to 2008. You can see that the mortality rate per 100,000 maternities in 2004 to 2005, or I think 2003 to 2005, was 1.94. And it suddenly dropped to 0.79 per 100,000 maternities in 2006 to 2008. There was a sudden drop in the maternal mortality. Interestingly, this statistically significant decrease in maternal death due to venous thromboembolism in this era was noted after the first publication of the RCOG guidelines for thromboprophylaxis during pregnancy and after vaginal delivery. The 8th report on the confidential inquiries into maternal deaths in the UK also published this, and it was found that VTE was the leading cause of direct death in the UK for all but the final of the 2 years, which I showed you, more than other causes like sepsis, preeclampsia, amniotic fluid embolism, or hemorrhage. Coming to some anatomical and physiological facts in pregnancy, we know that venous thromboembolism is common in pregnancy more on the left side. This happens because the left common iliac vein is compressed by the right common iliac artery. And it's also noted that that's why we found that the incidence of DVT is around 88% on the left side in pregnancy compared to 55% in non-pregnant women. Also, we noted that the DVT is more proximal in nature in pregnant women compared to non-pregnant women. The difference is from 71% in pregnant women compared to 9% in the non-pregnant population. Also, we found that 64% of these DVTs were restricted to the iliac and or the femoral veins. We know that the daily risk of this pregnancy-associated VTE is very important during the first 3 to 6 weeks postpartum, but we should also remember that this risk declines but remains up to around 12 weeks postpartum. Now you can see clearly in this graph the risk of or the incidence of VTE as per the trimester. And the first trimester is around 10.1%, the second trimester 10.4%. It jumps up in third trimester to 28%. And you can suddenly see after delivery in the postpartum period, the first 6 weeks, it goes up to 50%. And then it comes down slowly and it remains with a small risk in the next 6 weeks up to 12 weeks postpartum. Now, the RCOG published these guidelines for reducing the risk of thromboembolism during pregnancy and puerperium, and we have adapted our guidelines from this RCOG guideline as well as our COG guidelines and the American College of Chest Physicians. The first guideline was published in our hospital in 2011, which included only the postpartum period. Gradually, we also published the antepartum and postpartum guidelines, and we have been revising it every 3 years, the thromboprophylaxis guidelines. Also, we have this as a KPI indicator for our hospital, and we have been having some workshops since the last 4 years to create awareness about the risk of thrombosis in pregnancy. Now, when you want to reduce this risk in pregnancy or the postpartum period, it needs a 3-step approach. We should know which women are at the greatest risk, or we should know how to risk stratify them, and then we should appropriately give them the proper regimen for the proper duration and time. We should know how many days or how many weeks they require thromboprophylaxis and what dose they require, or do they need any expert advice or guidance. Now, this was the form, which was a manual paper form, which we used to put in the files when our electronic medical record system was not yet done. We started the electronic medical record system in 2017. Before that, this paper was put in every file. And then the doctor who was to do the risk assessment was to fill these data, score the risk factors. You know, this form is very well available in the RCOG guidelines. This has 2 parts, the antepartum and postpartum. The boxes have colors like red is high risk, and the orange is intermediate risk, and the yellow is low risk, and the green is like the lowest, I should say. Now, scoring is done by tick marking the various boxes, calculating total risk, and then this form also had the BMI And on the right-hand side corner in the below, it is having the weight and the dose of Clexan, because we are using Clexan as the preferred low molecular weight heparin in Latifa Hospital. So we had put the doses for Clexan. Now we have the electronic system. So we have this form incorporated into the electronic medical system, and the doctors are using it. And it's quite a user-friendly form. Now, adequate use of venous thromboembolism prophylaxis is considered an indicator of quality of care in any medical institution. Coming to risk stratification in pregnancy. All women should undergo documented assessment of risk factors in early pregnancy or even pre-pregnancy. Those who are at high risk, in fact, very high risk, like those patients who had venous thromboembolism even before they become pregnant, or they have a past history of recurrent venous thromboembolism, or they have a high-risk thrombophilia, definitely they need to be assessed even before pregnancy so that the proper dose of the thromboprophylaxis could be started for them. This is the form for antenatal VTE risk assessment. It looks like a lot of risk factors, but I'll try to explain to you everything and try to make it easy for you to understand. The basic principle is that you need to score the risk factors, do the counting, total calculation, and then depending on the total calculation, you decide what the patient will need. Now, there are some pre-existing risk factors, as I was talking about. So any patient, if she has a previous DVT before getting pregnant, and that DVT was not related to any major surgery, definitely she will need thromboprophylaxis from the start of pregnancy, and the dose will be depending upon other factors, which I will discuss later. So any previous VTE not related to major surgery, she should be on thromboprophylaxis from the start of pregnancy till 6 weeks postpartum. But remember, every patient has to have a risk assessment at delivery. The other high risk scoring is done for known high risk thrombophilia. High risk thrombophilias again are scored for because these patients have high risk of developing venous thromboembolism in pregnancy, or even they might have a previous history of thromboembolism. Now, the thrombophilias, I will just try to make them simple for you. They are either hereditary or acquired. The acquired one we all know is the antiphospholipid syndrome. The hereditary ones are divided into low risk and high risk. Any thrombophilia which is heterozygous, it is a low risk thrombophilia. For example, if I say that factor V laden heterozygote, this is a low risk thrombophilia. If I say prothrombin gene mutation heterozygous, again, this is a low risk thrombophilia. When I say factor V laden mutation homozygous, or if I say prothrombin gene mutation homozygous, it becomes a high risk thrombophilia. Also, combination of two heterozygous defects, for example, factor V laden heterozygote and prothrombin gene mutation heterozygous. So these two combinations, 1 + 1 becomes 2, and it becomes a homozygous defect, like similar to a homozygous defect, and becomes a high risk thrombophilia. Also, I would like to mention that antithrombin deficiency is one of the very high risk thrombophilias. Now, if a patient has gives you a history that she had a venous thromboembolism related to major surgery in the past, then such patients have been scored 3, which means that they will be given thromboprophylaxis from 28 weeks of pregnancy, and then they'll continue for 6 weeks postpartum. Coming to the medical comorbidities. In the medical comorbidities, there are a lot of comorbidities mentioned and scoring given. Now, as an obstetrician, you might have confusion related to these comorbidities. If you're in doubt, or if you don't understand them, it's a nice thing to refer them to the particular subspecialty. It's best practice, or it's good practice to refer them to the specialist services to find out exactly what they stand, where they stand, how much dose they will require, or whether they will require or not require thromboprophylaxis. So not all cancer patients require thromboprophylaxis. There are various scoring methods used wherein they look at the type of cancer, the site of cancer, whether they have undergone surgery or chemotherapy, they are immobile, their BMIs. So depending on the scoring of the cancer, it requires thromboprophylaxis or not. So not all patients. A patient who had breast cancer 10 years ago and now she is stable, perfectly healthy, she would not require any thromboprophylaxis. A patient of heart failure, we have sometimes patients with heart diseases, cardiomyopathies, etc. These patients, if the ejection fraction is less than 30%, only then they would be candidates for thromboprophylaxis. The other golden rule is for the active inflammatory bowel disease, inflammatory arthropathies. Whenever there's inflammation, we need to see that the patient is in active disease. Only if she is in active disease, then she will require thromboprophylaxis, not if she is in remission. Sickle cell disease, we know that sickle cell trait and disease both are at high risk for thrombosis. But sickle cell disease per se, if she has recurrent admissions or hospitalizations, or she has past history of clots, definitely she will be for thromboprophylaxis throughout pregnancy. A sickle cell trait patient might be given thromboprophylaxis when she's admitted. Coming to type 1 diabetes with nephropathy. So please understand that if patient of type 1 diabetes has proteinuria, which is more than 5 grams per day, she would require thromboprophylaxis, because when they lose protein, they also lose antithrombin in their urine and they become deficient. So they become a candidate for thromboprophylaxis. Coming to SLE, we all have confusion about this topic, SLE. Again, there's a SLE disease activity index. It's called the SLEDAI. The SLEDAI score, there are many points. I have put it on this table, like, the lab markers, the clinical markers, and many other things. When you totally count them, if the score index is more than 8, then we can justify that this SLE disease is active now, and she would require thromboprophylaxis. Nephrotic syndrome. Patients who have nephrotic syndrome, if the serum albumin is less than 2, it's considered a risk factor. In case of membranous or lupus nephropathy, if the serum albumin is even less than 3, they're considered as high risk for thrombosis. To the pre-existing risk factors, there's a long list, and each of them is scored 1. So when you add them and they become 3 or 4, then it becomes significant. For example, family history of unprovoked or estrogen-related VTE in first-degree relative. Next is low-risk thrombophilia without any VTE. Age more than 35 years. BMI from 30 to 39.9. Parity more than or equal to 3. Smoker, and gross varicose veins. Gross varicose veins means that the patient has gross varicose veins above the thigh level, above the knee level in the thigh, and they're usually tortuous with phlebitis or pain. Those are considered gross varicose veins, not the thin veins which are sometimes seen in pregnant women on the ankle or the leg. So they describe gross varicose veins in this way. Now coming to obesity, obesity has been found to be a risk factor, especially the morbid obesity, BMI more than or equal to 40. That's why they gave it a score of 2. Now coming to the obstetric risk factors, for example, preeclampsia in this pregnancy will be scored 1. Artificial reproductive therapy or intravenous in vitro fertilization will be scored 1. Multiple pregnancy and stillbirth in current pregnancy again would be scored as 1. So the final thing is, now the main important thing which I want to talk about today is also about the transient risk factors. Transient risk factors could be any surgical procedures or hyperemesis or within hyperstimulation, infection, immobility, dehydration. The guideline very clearly mentions that we should start thromboprophylaxis when the patient has these transient risk factors and continue them till the risk factor resolves or is no longer present. Now, coming to, for example, hyperemesis, this is a very important point which I want to say today, that patients who are hyperemesis and they are admitted with it, they already are dehydrated. So we don't follow the policy that if admitted for 3 days, then you start thromboprophylaxis. No, a hyperemesis patient is already dehydrated, start thromboprophylaxis immediately on admission, and please continue till you feel that patient is taking well orally. And even after going home, you can continue it for 1 or 2 weeks, depending on her condition. Once you are assured, explain to the patient the risk of thrombosis because of dehydration, and tell her that when you feel that you have enough water intake and you're eating well, there is no dehydration, only then you are supposed to stop the thromboprophylaxis. Even I would say continuing throughout the first trimester also would be advisable in severe hyperemesis patients. Until the infection resolves, we have to continue the thromboprophylaxis. So as we discussed, it was a summary of the total thing, that if the score is more than or equal to 4, you give it thromboprophylaxis from the first trimester itself. If the score is 3, you start from 28 weeks of pregnancy. Any admission, consider starting thromboprophylaxis. And if the score is less than 3, mobilization and avoidance of rehydration. So a short summary of the clinical conditions we sometimes see in the first trimester. For example, ovarian hyperstimulation syndrome, you should continue it in the first trimester unless there's any contraindication. And if there is severe ovarian hyperstimulation syndrome, at least 8 to 12 weeks after the resolution of the syndrome, you could stop the thromboprophylaxis. And for any woman who has an increased risk for thromboembolism during assisted reproductive therapy, you should start thromboprophylaxis at the time of ovarian stimulation. And if a woman develops a DVT in the association with the use of protective therapies. Again, 3 months from therapeutic anticoagulation, and woman with an IVF pregnancy, if she has 3 other risk factors, it becomes 4. Then she can start thromboprophylaxis from the start of the first trimester itself. Now, these are some interesting scenarios which all of us get confused in antepartum women. As I told you, antithrombin 3 deficiency is one of the very highest thrombophilias amongst the heritable thrombophilias. Similarly, antiphospholipid syndrome is one of the very highest thrombophilias in the acquired syndromes. Now, let us discuss some scenarios and how will you deal with them. Any patient who has antiphospholipid syndrome with prior either arterial or venous thrombosis, but without APS defining pregnancy morbidity, such patients will be on therapeutic dose low molecular weight heparin and low dose aspirin. So I should repeat that antiphospholipid syndrome, along with past history of arterial or venous thrombosis, is a very high risk situation. Thus, patients will need therapeutic dose low molecular weight heparin with aspirin, and of course, postpartum they will require. They'll be shifted to warfarin for an indefinite period of time. They should be under the care of the hematologist and the expert doctors. A patient who has antiphospholipid syndrome based on lab criteria and she has an APS defining pregnancy morbidity, for example, more than or equal to 1 fetal loss, more than or equal to 10 weeks gestation, or unexplained consecutive spontaneous miscarriages, less than 10 weeks gestation, but no history of arterial or venous thrombosis. So here there's no venous or arterial thrombosis, but there's a pregnancy morbidity. Such patients will require prophylactic dose low molecular weight heparin with aspirin. Antepartum and postpartum also, they'll require the same for 6 weeks. Coming to the third scenario where the patient has antiphospholipid syndrome based on lab criteria, and also she has an APS defining placental morbidity, like for example, more than or equal to 1 preterm delivery due to preeclampsia or eclampsia, like findings consistent with placental insufficiency, but she doesn't have a history of arterial or venous thrombosis. In this patient's most cases, you require low dose aspirin. But if aspirin fails and the placental examination shows that there is a lot of extensive placental inflammation going on, or vasculopathy or placental thrombosis going on, such patients could be given prophylactic dose low molecular weight heparin along with the aspirin therapy. Postpartum vaginal delivery, they will require only aspirin. If cesarean delivery, they'll require low molecular weight heparin and aspirin for 6 weeks. Now, there are many situations where you find that the antibodies are positive, just called as lab criteria for antiphospholipid syndrome. So you might have a anticardiolipin antibody positive, or other lupus anticoagulant positive, or antiphospholipid antibodies positive, and also significant persistently. But there is no history of either obstetric history, or there's no history of arterial or venous thrombosis. Such patients will require just low dose aspirin, but consider it as 1 score. So when you are scoring them antenatally for the risk factors, this is 1 point. So if she has other risk factors like age or parity or BMI, and this will be also 1 score counted. So it will be added on. Such patients, if they have a normal vaginal delivery, they'll be on low dose aspirin for 6 weeks. But if they have a cesarean delivery, they'll be on prophylactic low molecular weight heparin with aspirin for 6 weeks. So I think the take-home message in this slide is that arterial or venous thrombosis is a very important criterion, and antiphospholipid syndrome is a very high-risk situation. This slide is regarding a guideline or summary of guideline for women who had past history of venous thromboembolism and they have thrombophilia. The thrombophilia could be low risk or high risk. Coming to the first case scenario, which is very, very high risk. Again, I told you antithrombin 3 deficiency, antiphospholipid syndrome with a previous history of DVT, or a previous DVT with a patient on long-term anticoagulant therapy. Such patients are recommended high dose or sometimes even therapeutic dose of thromboprophylaxis antenatally and for 6 weeks postnatally. Some patients among them will require special advice or expert opinion, and they would be shifted to oral anticoagulation throughout their lives, especially antiphospholipid syndrome or antithrombin deficiency with past history of DVT, or a patient who has a recurrent DVT in the past. The second group is the high-risk patients. So any patient who had a past history of DVT is a high-risk patient. As I told you, they'll require antenatal throughout pregnancy and 6 weeks postnatal. Intermediate risk are those patients who are high-risk thrombophilia, but they are asymptomatic, and they will require again same antenatal and 6 weeks postnatal, and they could be referred to the local expert because they are high-risk thrombophilias. A single previous DVT with major surgery and without any other history, like without family history or other risk factors or without thrombophilia, they will start from 28 weeks of gestation and they will take it up to 6 weeks postnatal. Now, the low risk is the low risk thrombophilias, which are asymptomatic. So they don't have any past history of DVT. They will be taking as 1 point, this will be as 1 score, and score appropriately along with the other risk factors. Postnatally, they will take this thing 10 days. If other risk factors are present, add them, and then they might require 6 weeks. But if a patient of low risk thrombophilia, if this patient has a family history of DVT in a first degree relative at the age of less than 50 years, so a low risk thrombophilia patient, a pregnant patient comes to you and she's low risk thrombophilia, but she tells you that a relative, first degree relative, has a history of DVT below the age of 50 years, then this is a high risk situation. She will need thromboprophylaxis 6 weeks postnatally, but antenatally this will be scored as 1 point. During delivery, there are many questions asked that when should we stop low molecular weight heparin? So any woman who is having any bleeding antenatally or during the period of once labor begins, they should stop it immediately and then come to the hospital and then decide it further by the hospital staff whether she's in labor. And then depending on the situation, you continue or discontinue it. And a woman who is having a cesarean section, which is elective, then suppose she is on Clexan once a day, low molecular weight heparin once a day, she should stop it 1 day prior to the date of elective cesarean. In case patient is taking it in the evening, for example, 6 p.m. she takes the Clexan dose, she can go for cesarean next day morning. So a minimum gap of 12 hours is at least required if you are planning an elective section. But ideally, if you could give it a 24 hours gap, is also considered a good practice. A woman suppose she's at high risk of antenatal hemorrhage, or she has coagulopathy, or she has, for example, a wound hematoma or some suspected bleeding, then of course you have to stop the thromboprophylaxis. The other options in this case are the pneumatic compression devices or the foot impulse devices. And if a woman develops bleeding while she's on low molecular weight heparin, then you should stop the thromboprophylaxis. And once the bleeding has stopped and you consider the patient is safe, or you can start it, or you could take expert hematological advice. What are the contraindications to this use of low molecular weight heparin? Known bleeding disorders, active bleeding, placenta previa, platelet count of less than 75,000, acute stroke in the past 4 weeks, which could be either hemorrhagic or ischemic, GFR less than 30, severe liver disease or uncontrolled hypertension, and the blood pressure is very high. Coming to postnatal thromboprophylaxis. So as I told you before, risk assessment should be done for women at least once following delivery and before discharge. Also, sometimes what happens is factor changes. Some patient may have prolonged admission. She might have some infection postpartum. She might have some surgical procedure postpartum. So always before she goes home, once again, you should do the risk assessment for these women. Also, it should be seen that patient learns how to take the injections at home, and the due prescription should be provided to her in the community wherever necessary. This is the postnatal VTE risk assessment form, again colorful, red, orange, yellow, and there's scoring for each risk factor. Most of these factors are same, but there's a bit of a few changes which I would just discuss with you. Now, which are the high-risk patients postpartum? So any patient, any woman who had a VTE in the pregnancy or previous pregnancy or in the past, so she will be on thromboprophylaxis antenatally. So basically, any woman who was antenatally on thromboprophylaxis throughout pregnancy will be definitely postpartum for 6 weeks or even more, depending on the risk factors. Any patient who has known high-risk thrombophilia, any patient who is known low-risk thrombophilia, but she has a family history of VTE in a first-degree relative, as I told you before. So these patients should be given 6 weeks postpartum thromboprophylaxis, regardless of the mode of delivery. Now, all these are the same risk factors as we did antenatally: the age, the BMI, parity more than or equal to 3, smoker, gross varicose veins, known low-risk thrombophilia, or a family history of unprovoked or estrogen-provoked DVT in first-degree relative. So BMI more than or equal to 40 is considered a score of 2. So all women who have class 3 obesity, suppose they don't have any other risk factors, but they have class 3 obesity and the BMI is equal to or more than 40 should be considered for thromboprophylaxis for 10 days. So a score of 2 postpartum is considered for 10 days. So any patient who has an emergency cesarean section, again a score is given 2 for these patients, and such patients also should be on thromboprophylaxis for 10 days. Elective cesarean section is scored 1, so that if they have other risk factors, then counting is more than 2 or 2, then they can be given thromboprophylaxis. So preeclampsia, multiple pregnancy, elective cesarean section, mid-cavity or rotational operative delivery, prolonged labor more than 24 hours, postpartum hemorrhage, which is more than 1 liter, or receives transfusion, preterm birth or stillbirth. These are all scored 1 in the obstetric risk factors. Again, the topic is of transient risk factors. So as we discussed before, any transient risk factor or prolonged admission or wound infection or surgery in the postpartum period, these are all transient risk factors. These risk factors, patient should be given thromboprophylaxis either till the risk factor is no longer present or for 6 weeks. You can consider extending it up to 6 weeks. This is a summary of the risk factors. So any patient who had antenatal thromboprophylaxis should be for 6 weeks postpartum. Any patient who has a past history of VTE will be for 6 weeks postpartum. Any known high-risk thrombophilia will be for 6 weeks postpartum. And any patient with low-risk thrombophilia with family history of VTE in first-degree relative will be for 6 weeks postpartum. So any score less than 2 will be for avoidance of dehydration and mobilization. Any score of 3 and 2 will be for 10 days. Any score of more than 3, like 4, 5, 6 should be considered for 6 weeks thromboprophylaxis. Now, there is also a lot of talk about mechanical and combined, like mechanical and pharmacological thromboprophylaxis. This should be given to patients who are very high risk for DVT. For example, past history of VTE, score of more than 4 antenatally when she's admitted, or postnatal more than score of 3, and a woman traveling for long distance more than 4 hours. They could be given the stockings also. These are recommended things. Recommended are the stockings for these patients who are traveling more than 4 hours. General advice for traveling for women when they're traveling for a flight, which is off flight or by road or whatever, when they will be probably immobile for over 4 hours. We know that wearing loose clothing, comfortable shoes, walking regularly, drinking a lot of water, etc. is recommended for them. Also, they could use compression stockings, which will give them a proper pressure and it will improve the venous returns. Now, coming to the incidence of side effects related to low molecular weight heparins in pregnancy. So the risk of bleeding, the first column is therapeutic dose, second is prophylactic dose, and the third column is any dose. So antepartum bleeding risk is very low, 0 to 0.57% in therapeutic dose. Postpartum bleeding is 1.15 to 5.6%. Wound hematoma is 1.39%. Allergy or skin reaction is 1.15%. And heparin-induced thrombocytopenia or osteoporosis is 0%. And of course, the prophylactic dose, the risk even goes down. So I think the risk of bleeding or other things is quite low with these. They're considered quite safe in pregnancy and the postpartum period. These are the doses. I will not go in detail, but these are the doses for therapeutic dosing for different types of low molecular weight heparins. And if you're giving warfarin postpartum, the INR should be maintained between 2 and 3. These are the protocols for prophylactic dosing for various types of heparins, and as per the weight, they are adjusted for different trimester for the different patients. Sorry. And now we should all know that while thromboprophylaxis would reduce the risk of VTE in hospitalized patients or otherwise, importantly, they should be aware that it does not eliminate the risk completely. It would reduce the risk, but not eliminate it completely. Also, whenever you assess a patient, do a full history examination and clinical assessment for both the risk of thrombosis and the risk of bleeding. Now, we all know that low molecular weight heparin is the preferred anticoagulant for the management and treatment of venous thromboembolism in pregnancy. And we also know that unfractionated heparin, low molecular weight heparin, and warfarin are safe for the breastfed infant when administered to the nursing mother. Also remember that the oral direct thrombin and factor Xa inhibitors should not be used while breastfeeding. Now, many patients come back to us with these type of bruises when they take Clexan. Please try to differentiate between bruising and allergy. If they have itching, they have erythemas, they have they complain. One patient complained to me of like fire burning under the skin, and the next day she had all redness and induration and itching. So Clexan allergy is known. We have quite a few patients who come to us with Clexan allergy. What we do is, first of all, we try to give them antihistaminics or steroid creams, local application, and try to change the site and explain them, then the technique of taking the injection properly. Still, if it persists or it is worsening, then we try to change it to tinzaparin, from the Clexane to tinzaparin. But as you know, they are the same group of drugs. Some patients do tolerate tinzaparin, but some patients would not even tolerate tinzaparin. In that case, we have a safe alternative, fondaparinux. Fondaparinux is also given once a day, and it's also a subcutaneous injection, but it has to be given with expert hematologist advice. And we have given it so far to 2 patients who had allergy to a bad allergic reaction to Clexane and tinzaparin. So take-home message is hospitalization is a major risk factor for venous thromboembolism, and VTE can be prevented with appropriate thromboprophylaxis. Thank you so much. So I would like to share some few cases, and we'll have our audience polling after that, and we'll give you 15 seconds to poll for the results. So my first case scenario is a 34 years old woman, para 1+0. She's 8 weeks pregnant with spontaneous pregnancy. She had a history of deep venous thrombosis when she was 20 years old while in Egypt and does not have explanation or medical reports. She has no significant family history of any venous thromboembolism, and her BMI is 24. So what would be your option for the thromboprophylaxis? Could we start the audience poll, Karishma? So could we have the polling results, please? Yes, 78% have answered correctly. I'm very happy to see this response. As we know that she's 34 years old, so NATO risk factor parity is not more than 3, and there's a spontaneous pregnancy. The only significant point here is that she has a past history of DVT, which is a very strong high risk factor. So she will require antenatal and postnatal thromboprophylaxis. Well done. So can I go to the second case now? Karishma, the slides are not moving. Okay, but my slides are not moving, Karishma. Okay, 38 years old, para 1+0, 7 weeks pregnant lady, IVF pregnancy, admitted for hyperemesis. No family history of venous thromboembolism, non-smoker, and has left leg significant gross varicose veins. So could we start the polling, please? केस 1 से केस 2 पे नहीं जा रहा था. Okay, so the answer, could we have the polling results? Okay, the correct answer would be C, which is 44% have answered correctly. So see, in this patient, age is a risk factor, IVF pregnancy is a risk factor, and also she has significant gross varicose veins. She has 3 risk factors. So anybody who has 3 risk factors antenatally will take thromboprophylaxis from 28 weeks onwards. But now she has a transient risk factor for hyperemesis. So we have to give her thromboprophylaxis now because she's admitted. So we'll give her thromboprophylaxis till the hyperemesis resolves, and then we'll start her on thromboprophylaxis from 28 weeks onwards. Okay, the third case is a 32 years old lady, para 2+0. Her mother had DVT at the age of 40 years unprovoked, and patient has protein S and protein C deficiency. Her BMI is 28. Could we have the polling, please? Could we have the results, Karishma? I think the answer here is B, which is intermediate dose thromboprophylaxis, both antenatal and postpartum. Patient has both protein C and protein S deficiency. So when there are 2 defects, it becomes a high risk thrombophilia. As I explained to you, if it's 1 defect, like say, for example, heterozygous protein C deficiency, she would be low risk. But in the combination of 2 defects, consider them at high risk of thromboprophylaxis. So here they will require, instead of prophylactic dose, you have to consider giving them intermediate dose. What do you mean by intermediate dose? Is 1 milligram per kg once a day. The therapeutic dose is normally 1 milligram per kg twice a day when we treat thromboembolism. So prophylactic is 1 milligram. Prophylactic is as per the body weight of the patient. So intermediate or high prophylactic dose is 1 milligram per kg once a day. So the answer here is B, which is intermediate dose. Could we go to the next question, please? So para 4+2, 6 weeks gestation, IVF pregnancy, 35 years old with a BMI of 36, past history of DVT 2 years back, antiphospholipid syndrome. Her last pregnancy, she had severe preeclampsia and was delivered at 30 weeks. So could we have the polling, please? Yes, could we have the results? 71% have answered correctly. That's a very, very, very good response. I'm very happy with this question, because as we understood that antiphospholipid syndrome is a very high risk scenario. On top of that, she has a past history of DVT. That's why she will be on therapeutic dose during pregnancy, and also aspirin will be included, and postpartum she'll be on anticoagulation indefinitely. Also, you can see here that she has multiple other risk factors: her parity, her age, IVF pregnancy, her BMI, everything is there. Of course, she's a very complicated case with very high risk thrombophilia. But my aim to put this question was to reinforce that antiphospholipid syndrome is the highest, very high risk thrombophilia with a past history of DVT. Well done. Could we go to the next question, Karishma? Yes. So 40 years old, para 0+5, BMI of 42. She has heterozygous prothrombin gene mutation. She's admitted at 6 weeks with ovarian hyperstimulation syndrome, IVF pregnancy, singleton, hyperemesis, and no personal or family history of DVT. So postnatally, she was induced at 38 weeks. She had an emergency section and blood loss of 1 liter. So could we have the audience poll, please? Okay, could we have the results? Yes, 84% have answered correctly. That's very good. So this patient has age 1 point, BMI is above 40, so 2 points. She has a low risk thrombophilia, which is heterozygous prothrombin gene mutation. She has IVF, which is 1 point, and ovarian hyperstimulation syndrome, which is of course transient, but the other risk factors already we counted is 4. So she'll be on antenatal thromboprophylaxis. Postpartum, she has an emergency section, which is 2 points, plus a blood loss of 1 liter, which is 1 more point, and plus the previous factors, age, parity, BMI. So she definitely requires antepartum and postpartum 6 weeks. Well done. So this completes our questions. I think most of them have understood the concepts behind thrombophilias and high risk patients for thrombosis. Thank you, Karishma. Thank you very much.
Thank you very much, both our respected speakers. And I have just about time for 2 questions. I would like to ask the first question to Dr. Komal. Dr. Komal, there's an anonymous attendee who has presented a question asking us what is the rationale behind stopping aspirin or Clexane, aspirin before 32 weeks gestation and Clexane at 40 or before elective LSCS. What is the rationale? I think you have to unmute yourself, Dr. Komal. Yeah.
I'm unmuted already. Can you hear me, doctor?
Yes, we can hear you now.
Okay. The rationale to stop aspirin is to prevent the bleeding during delivery or during cesarean. That is the rationale. Now, to stop Clexane, there is no, the protocol for stopping Clexane again is to prevent the bleeding, of course. So when the patient is on therapeutic Clexane, we stop it 24 hours before the surgery. If patient is on prophylactic, you could stop like even 12 hours before the scheduled surgery. The only thing we want to prevent is the excess bleeding.
Absolutely. And what would you say are the DHA recommendations in restarting the therapeutic as well as prophylactic?
Yes, we have very clear recommendation, doctor, that once a surgery is done, after 4 to 6 hours, or in some cases on therapeutic Clexane, maybe 6 to 8 hours, you need to reassess the patient's bleeding status. If there is no more bleeding, the bleeding is acceptable by the obstetrician, then we can restart Clexane as soon as possible. So maximum time could be 6 to 8 hours.
Okay. Thank you, Dr. Komal. And I have the next question for Dr. Saleema, a very interesting question, which has also come from an anonymous attendee, who is saying that postpartum, what weight should we consider for BMI calculation? Present one or before present one or before pregnancy weight? And the person also mentions that the Canadian guidelines are in favor of less thromboprophylaxis and also considers the concern of the patient for the risk of hemorrhage. The patient can choose whether to take thromboprophylaxis or not. What is your opinion in this matter?
A very interesting and a very long question to answer. Yes, I do agree. It's not only Canadian, it's even American ACOG guidelines. They are much lower in usage. I have one slide in which I could show you that how much is the difference in use of thromboprophylaxis by 3 major guidelines. Even if you say American chest physicians guideline, there's a huge difference. If you go from that point of view, yes, the RCOG are more liberal in using the thromboprophylaxis, whereas Americans and Canadians are less in use of thromboprophylaxis. They are more in favor of using thromboprophylaxis, especially in patients who are very, very high risk of VTE, like patients who have previous VTE or patients who have comorbidities. As such, if you ask me, their guidelines are very, very conservative in giving thromboprophylaxis. Now, the question comes, how much is the risk of bleeding? The risk of bleeding is very small. When you compare the problem and the issue, the risk of bleeding is there is a very good article, if somebody wants to read the controversy, that's from Kostau, and he has written a very good debatable article that thromboprophylaxis is overused. Again, it depends what risk you are ready to take. And I don't think I want to take a risk with a VTE because I know they can die as well. So again, depends. When I have a safer thing to do, I would go for thromboprophylaxis, and that's my honest opinion, and because I have seen the deaths due to VTE. And the second part of the question was related to mainly it was the difference, and the second part was related to
patient refusing
thromboprophylaxis.
Yes.
The right. to choose or not to choose. But it depends on how you counsel. Don't give a biased counseling. Give a counseling on both sides, the benefits and the risks. And at the end of the day, I respect my patients, provided they understand the risks and benefits. And I would document in my notes what her perception is, and she has her own way not to do it. Yes, at the end of the day, it's the patient choice.
And also it is important as a clinician also to be safe and document if the patient refuses any treatment on paper.
But not to say patient refused. Write down what her comments are in detail, because if tomorrow she develops a DVT or she goes into PE, that will be an issue. I think from the aspirin, there was a question regarding aspirin to stop at 32. I never stopped at 32. If you have to stop it, you only need a week before, because you want that cyclooxygenase cycle to come back. I would say if I have to stop aspirin, I would stop it at 36, not at 32.
True. Thank you, madam. And I have just one last question. It's come from our YouTube channel by Dr. Manpreet Kaur. And she says, madam, at what dose of low molecular weight heparin could you use for an obese non-PE post-LSCS patient?
Okay, it doesn't matter. I will use the same, because she doesn't have any, other than obesity, she doesn't have any other risk factor. I will use 1 milligram per kilogram body weight. If I feel, because or I can use just the prophylactic dose depending upon, like I have patient, for example, 150 kilos. What dose I am going to use? I will use the biggest dose, because I know she's a very high risk. She's BMI around 50. So possibly at 1 milligram per kilogram body weight, but not BD once.
And Dr. Manpreet also wants to know, what low molecular weight heparin do you suggest and prefer as the best out of the three?
I would say I'm not going to promote any company. It depends on specialty and what you are comfortable to use it. Like I would say we are used to the enoxaparin. Doesn't mean that I'm promoting that. I mean to say the question is low molecular weight heparin. Choose what is easier, what is less costly. And I have some of the patients who need twice dosages. They will not like twice dosage. They might go to tinzaparin to have a once dosage. So it's the patient. Again, talk to your patients and see how much they can afford to buy it, because it's too expensive.
Also, it's the availability of the drug, because sometimes in private, enoxaparin is not available and we have to make do with tinzaparin. So
that I wouldn't take a choice out of this. Yeah.
Thank you. Thank you so much, both of you, Dr. Saleem Awani, Dr. Komal Hazari, for such an excellent session and a wonderful presentation. And EMA OBGYN Society thanks you wholeheartedly for educating us yet again on this vital topic of vascular thromboembolism in pregnancy. I would also like to tell our viewers who are watching us on the YouTube channel and also on live streaming that we are also going to come up with another webinar on new frontiers in management of anemia, but also know that your CME will be available in the next 14 days. You have to fill out an evaluation form and answer the post-webinar quiz that will be sent to you on your registered email ID to obtain the CME credits. The webinar also will be available on demand on the YouTube channel, which is given on your screens. So you could attend that webinar in detail if you've missed any slides or do have any doubts from our esteemed faculty. And I will see you again soon. I'm thanking you for attending the VTE Prophylaxis in Antenatal and Postnatal Pregnant Women webinar. Please join us for the next Emirates OBGYN Society webinar on the 21st of January 2022 on new frontiers in management of anemia. Thank you very much.